basically I plan 4 times, separate 4 lectures about stroke. Because now the most of the stroke, most of the patients is stroke in our hospital. About 40% of inpatient is stroke. So I think everybody should understand more about stroke, and also very common in Cambodia. So today my topic is about ischemic stroke, especially acute phase. So some simple non-medical staff should understand some part, but also for medical staff, better to understand more professional point also. So number 1 question, what is stroke? Anyone can answer? What is stroke? Terry-san, can you answer?
Stroke is
Brain
vessel or accident.
Brain vessel accident. Yes.
Then no blood supply to the brain.
No blood supply to brain. Okay. Yeah. So maybe 50%. You explain. Any other opinion? Anyone? No. Tom-san. So brain vessel problem cause brain blood flow stop. Any other point?
It's a poor of blood flow to supply to the brain and poor nutrition support to the brain. And
Yes.
due to it's a kind of any block of the vessel is blocked by blood or something.
So same of it. Yeah. Another point, so brain vessel problem. Yes. And after brain vessel problem, nutrition decrease. And after nutrition decrease, function decrease. Right? Brain function decrease. One more thing, one more point. Anyone? No? Okay. So one more important is suddenly it happens. Sudden loss. So that's why very important for acute management. So we also call brain attack. It's a similar heart attack. Heart attack also have suddenly heart vessel block and heart function, heart nutrition support decrease and heart function decrease. So the same as brain stroke, brain attack is suddenly and blood flow to the area is cut off, then abilities decrease. So these 3 points, please remember. Stroke. Okay. So if you have any questions, please let me know. Maybe I will finish 30 minutes long. So actually there are no big data about Cambodian incidents. So maybe better we should summarize. In Japan, this is number 4th cause of death. Previously number 3, but now decreasing. Cancer, heart attack, pneumonia, and stroke now. And also it's gradually decreasing. Other 3 is increasing, but stroke decreasing. Because our management, internationally we understand management plan and many good medicine treatment. So many patients can survive now. But the number one cause of care after survive, but the handicap, many patients handicap. So still very important, one of the most important disease in Japan, and similar in Cambodia. I think Cambodia, some data from Carmet Hospital, number one cause of death is stroke. Some statistic from Carmet, but actually not well understand about it. So there are 4 types of stroke. So third brain attack. One is ischemic stroke. This is today's theme. I explained later. This is more than 70% in Japan. Also similar in all other countries. Cambodia very young population, so maybe a little bit decrease, but still number one cause is ischemic in Cambodia also. TIA is similar. TIA is transient ischemic attack, partially decrease flow but recover, we call TIA. So similar with ischemic. And hemorrhagic is another one, about 20%, less than 20%. It's a bleeding. Also it happens suddenly. I don't talk this hemorrhagic. And also another one, rupture of aneurysm, subarachnoid hemorrhage. Also very sudden onset and very severe disease. So there are 4 types, but the most common and most important is ischemic, because we can treat if we do emergency treatment. So again, the same topics. After it blocks, so ischemic stroke means blocking the vessel. Then gradually brain damaging because no nutrition, no oxygen. So within 3 minutes, the brain gradually become to die. Then loss of function happens. So there are 3 types of ischemic stroke. Also very important, and this is the Japanese classification. There are many other countries' classification. Usually in our hospital we use these 3. One is atherosclerotic. Atherosclerotic means vessel become hard and narrow. Basically because of diabetes, hypertension, smoking, very common in Cambodia. So one is atherosclerotic. Another one is lacuna. Lacuna means very small. So other classification we call toast classification. Toast classification we call large vessel or small vessel. But this is the same meaning. Atherosclerotic or lacuna. Lacuna means less than 1.5 centimeter. So very small, but the main cause is diabetes, hypertension, the same as atherosclerosis. And the different cause is cardiac embolization, which means some heart problem causes a clot in the heart. And then this clot jumps to the brain. So embolization, embolic stroke means most of the case cardiac, so the category is similar on this. So please remember these 3 categories. So the treatment plan may differ a little bit. So TIA, as I explained, this is blood flow stop and have symptom but recover. This is the category of TIA. So how many minutes or hours if patients recover we can call TIA? Anyone knows? Any nurse? Shinrai-san? for the definition, how many hours?
I'm not sure.
24 hours. So if there is stroke symptom, but within 1 day recover, we can call TIA. But most of the case are 10 minutes or less than one hour. Yeah.
So for the TIA, even though on the brain imaging there's a small spot of infarction, we also can call TIA or like
Yeah, it is actually it's very vague. This category based on the symptom. So even if imaging have stroke, but recover within 1 day, we can call TIA. Yes. So non-symptomatic stroke with symptomatic TIA area, and it recover, we can consider. So this we can call this is based on the clinical condition. And most of the time, TIA is caused by narrowing of vessels, especially neck vessels. So this is a warning sign of ischemic stroke. If we don't start treatment, maybe stroke happen again. Permanent stroke may happen, ischemic stroke. So we have to categorize this similar ischemic stroke. Now very important. Okay, so today let's study about acute treatment of ischemic stroke. So what is a typical symptom of ischemic stroke? Anyone? Do you know anything about weakness of where? Which body?
extremity,
Extremities,
face palsy,
face,
slow speech.
slur speech. Okay, good. Third we call fast. Firstly, this is a poster in England. So we remember fast. We call this Cincinnati stroke scale. So everybody, for all citizens or ambulance crew, should understand fast. So if sudden onset of this symptom, face dropping, leg is also okay, but extremity dropping, slurred speech not fluent, this is a typical sign of stroke. Final T means emergency. So if this happens suddenly, please call immediately. So nationally we should in England have this poster, the similar poster in Japan, anywhere else. So maybe we can make Kumai version. Some die. I can only say die. DJ. Please. What's best? Moda DJ. So please make Kumai version. Okay. So other symptom also sensation problem or disorientation, which means cannot communicate or agitation, emotionally cannot control, loss of consciousness. Sometimes it happens. Loss of consciousness actually not common for stroke. If it happens by stroke, very massive stroke. But anyway, sudden onset is very important. So if suddenly happen, have to come emergency. If so, like OPD nurse maybe notice. Every time I ask, this is sudden onset or gradually, because the sudden is a character of vascular problem, stroke or heart attack or abdomen also. So very important, sudden onset. Okay. So time, because this 4-letter time is including, so why time is very important. The same question is, why should patients have to come to hospital as soon as possible? Want to do rehabilitation, emergency, or any other reason?
As Dr. Hayashi mentioned in the previous slide, after the vessel stroke, the veins and tissues will die little by little. So we need to take off or we need to take off or some treatment to restart the flow.
Yeah. Okay, thank you. Yeah, it's correct. So, yeah, as Ueno-kun said, if it this condition, we don't know if it's ischemic or not, bleeding or rupture, we don't know. But if it's ischemic, there is a chance to recover. So that's why we recommend to as soon as possible. So this is one illustration. So this is a blocking of the vessel. So if blocking continue, this red area is already died. The center area we call ischemic core. The surrounding area, if it's half, so half die but can recover if blood supply comes. So if this condition blood supply come, one way decanalize or deperfusion in English. If we remove this clot, maybe we can save surrounding area. So we cannot recover all ischemic core, center area already died because after 3 minutes cell start to die. But some lucky patients, if we recanalize, symptom completely recover, like last TPA patients. So that's why we try to do deperfusion. So if we continue occlusion, the damaging area becoming more fixed. Sometimes this fixing causes more worsening or clinically worsening. So several IPD patients complain worsening even after hospitalized, which means this symptom happens. So first time damaging area only center, but gradually surrounding area complete. So within 1 or 2 days worsening is this condition. So we call this surrounding area penumbra. Penumbra, explain English very difficult, but some anyone can explain penumbra. So surrounding of the core area and can say. So that's why we request to come soon. Okay. So from here, so maybe it's a little bit difficult for non-medical team, but medical team very important. So quickly share. So there are 2 ways to do treatment. One is TPA. TPA injection. Our hospital do 5 cases. Except one other hospital TPA includes 6 cases after we open. So just only injection. So very easy. Within 4.5 hours, we can do. So after symptom happen, quickly come. Within 4.5 hours, we recommend. And if ischemic stroke, we recommend TPA. So the very good point is very easy. Everybody can do, but there is a risk of bleeding, so we have to explain. So this is the summary of the study. Actually, this study is original study. Now we have many studies, but still this is a important number. So first study is within 3 hours, so a little bit different, but overall 30%, 1/3 patients improve. So 3% is worse. So this is what I explain to patients. So if you do accept this treatment, 30% patients improve because of this treatment. There are 3% of risk of worsening. So very obviously very good treatment. Actually no other treatment like aspirin taking or rehabilitation, surgery is not as good as this number. So still this treatment is number 1 recommendation for acute ischemic stroke. Actually the bleeding percentage is about 10%. So not so 3%. Bleeding 10%, but most of the bleeding is not worsening symptom, already damaging brain. So worsening only 3%. So that's the TPA. And so to do this TPA within 4.5 hours, so as early as quick as possible, we should encourage. So this time is a recommendation. So next slide is better, but in Japanese. So we call 7D. One is detection. So try to detection as much as possible. Dispatch, ambulance come, or they come by their cars, delivery. Door means hospital door. So when he arrived, door. So the time we have to improve the time is after door. So door to data. Data means not CT scan. Data means history. So after coming, we ask the history, onset time, past medical history, or past medication, contraindication, TPA or not, within 10 minutes. So if maybe the ER team asks the patient's history, and if it's possible of TPA indication, try to gather information. Before door is better, but maybe after door, after arriving, make sure the information within 10 minutes. So maybe some stroke committee or other teams better to check what time we finish this data. Then decision making within 25 minutes, which means CT scan should finish 25 minutes. So in our hospital, maybe very easily, not so big hospital, and very close to ER. So if we doubt TPA indication, maybe we can achieve 25. So doubting is very important. Then ask information, CT, there is indication. We should start TPA within 60 minutes. Some hospital recommend within 40 minutes, but as soon as possible is better. But maybe family have to think. So this 30 minutes is a thinking time, discussion time with family, because there is a risk, and also after patient decide, also maybe somebody already have experience to prepare. Preparation take time, maybe about 10 minutes or 15 minutes. Withdraw medicine, syringe pump preparation take time. So we have to do quickly to start medicine within 60 minutes. Any questions so far? So that's a TPA. Another one is a mechanical thrombectomy. So it's a catheter treatment intervention. So puncture the femoral artery from the side and put the catheter to the brain and remove the clot. So this is also good to treat, and there are many devices now. First one is we call mail sheets, are like a corkscrew, just insert and remove clot. But second generation is a penumbra. We have this penumbra. This is a suction. Put the catheter and suction. And latest and most effective is this stent. The name is Solitaire. Stent open to the clot and withdraw. Then we can remove. So this is within 8 hours we can do. But the weak point is we have to puncture clot and sometimes brain bleeding. There is a risk because we have to put many wires in the brain. So there is a little bit risky. But including this risky condition, if we achieve the perfusion, if we achieve clot, if we do mechanical thrombectomy, the more reperfusion achieved, more than 70% in average. And if we achieve reperfusion, this slide shows revascularize, the symptom improve very well. So if we cannot recanalize, revascularize, patient's condition not good for 40%. But if we achieve recanalize, 60% improve very well. So if this is some technology improve and then the perfusion rate improve and good outcome. Okay. So the time is very important because there is a chance to recover. So previously 20 years ago, no recover. When I'm a medical student, just start TPA. So it's very sensational. Then mechanical thrombectomy device when I become a doctor after. So very new one, but very important point. Then so already takes more than 10 years after mechanical thrombectomy technology started, and TPA started already 20 years. So there is a latest guideline from American Stroke Association, one of the biggest association, this year in April. So we should follow this guideline. So there are 3 important points. One is we should start TPA as soon as possible, as I explained. So we don't take time to take MRI or MRA. So strongly recommend to take CT, no MRI. So before this guideline happen, I recommend MRI, MRA also to make sure, but we change our management plan. So if TPA indication, take CT only. Also glucose, sometimes low sugar also causes stroke-like symptoms. So better to check sugar. On second point, as I explained, the golden standard time for mechanical thrombectomy is 8 hours. This one. Yeah, I like 8 hours. But some new study shows after 8 hours, number 3 I explained. After 8 hours, within 24 hours, so within 1 day, if perfusion MRI okay, I explain later, we can do mechanical thrombectomy. So I explained it. So more expand the treatment time. And second point, second point is the same as before guidelines. So even after TPA within 8 hours, MRI, MRA shows main artery occlusion. Let's do thrombectomy. So this is a perfusion images. So this is gray color is different from our machine, but this perfusion suggests this red area, big area decreasing of blood flow. And diffusion high means core damaging. So diffusion high basically cannot recover, but the perfusion high area, if there is mismatch, if there is a gap, this is a penumbra. So we can recover if we remove the clot. Another slide. So this is a similar of our image. So perfusion shows low blood flow at this blue area. But the diffusion shows only this small area here. So there is a mismatch. And MRI shows M1 occlusion, so blocking. So if we recanalize here, the rest of the area can save. So after 8 hours, we request to do perfusion MRI, but this needs some technique, right? So radiology technicians should practice to take perfusion, and then we should find the indication. Any question? Okay. So how much of TPA in our hospital? Do you know?
It's one set, $1,000.
One set, 1,000. But generally need about 4 sets or 5 sets. So around $4,000 or $5,000 necessary to use TPA. How about mechanical thrombectomy? So if you don't know price, maybe you cannot recommend patients or explain important. Okay, check some. How much do you think if we do thrombectomy? Yeah, you don't know, but if you meet your friends, family, ask you, if you say about $500, it's not good. So it's about $8,000. So more expensive. So if patients do TPA, but TPA not improve, and then next step go to thrombectomy, means more than $10,000. So very expensive. Not all people can accept without insurance, we know. So this is another issue to try to decrease price. So if we can buy TPA in cheaper price, we import from Japan both TPA or catheter. So if we can buy from other country, maybe we can decrease the cost, or some cheaper method or cheaper device if we can find, maybe we can set the price. Yeah, so this is maybe Ueno-san or warehouse team also should consider for that. But anyway, if we don't recover, patients die or bedridden, many patients, but after this treatment may recover more. So I skip MRS modified ranking scale is some indication of the condition. 0 is completely normal. 2 means small assist. So basically can walk by stick by himself. 3 means need more assist. 3 and 4 needs more assist. 5 bedridden, 6 die. So if we decanalize, so almost 60% can live, even if they are small handicap. So that's why we recommend this treatment. Okay, so main topic today I finish. So this is a summarize. So okay, within 4.5 hours, if there is symptom, sometimes very small symptom, only face dropping. Actually, we don't recommend TPA. So not mild is important. There is a checklist. And brain image, no bleeding or no big ischemic change, no. And artery don't matter because only CT scan, we don't know which artery blocking, so no problem. So symptom not mild, brain no big ischemic, we do TPA. And if TPA not improve or other reason, more than 4.5 hours patients come. And also main artery blocking, ICA occlusion, MCA occlusion by MRA, we do mechanical thrombectomy. Also, as I explained, after 8 hours, perfusion MRI shows mismatch. Until 24 hours, mechanical thrombectomy. So very complicated, so it's okay, not all, everybody remember all, but roughly within 24 hours, have to suspect the possibility and better to discuss the doctor or the ER nurse. ER nurse have to know. Okay. So how to assess symptoms for acute stroke? OPD nurse, Chibin-san, do you know?
Anything about like the waist?
First is normal people as a professional assessment.
Professional assessment for the patient is seeing about the when the patient have like onset, it have like the face drop face or like the arm drop down or something.
Yes. So there is some score.
Yes.
Do you know the name score? Anyone knows? NIHSS. So very small or very severe, we evaluate this NIHSS. There is some checklist. You don't have to remember there is a sheet in ER, just checklist, but you have to practice how to check. First ask what is your name, or which month is it, or anything like check sensation moving. Less than 4, we call mild stroke, no indication TPA or mechanical stroke. More than 5, we consider. And after this treatment, usually we should follow this NIHSS as ER-ICU nurse knows. How to assess brain image? Sophia? Sophia? Sophia. Radiology assessment. How? MRI, CT, both. How to assess ischemic? There is a score to check. They cannot make slide. So aspect. So the purpose to make score both NIHS and aspects is that everybody can understand the condition if you know, like GCS or JCS. So big stroke, small stroke is not good, so better to say the number. So aspect score, CT is maximum 10, MRI maximum 11. MRI at one coronal radiator area, middle area. But basically there are two levels, two slice level, basal ganglia level and ventricle level. Two slice and we check this area is ischemic or not. We score maximum 10 or 11 and we decrease if ischemic. So 0 means all black, all ischemic. So 11 or 10 are no ischemic. And if more than 6 if more than 6 more than half area of MCA is still preserving, still remaining, so we can consider mechanical thrombectomy. TPA also, more than 6 is good. Lower than 6, so 1 to 5, we should stop. So this one, so this slide, so CT scan, so maximum 10. This black area already damaged, so we decrease a few points. Then this is 0.4. 4 means maybe this M2, M4, M6, and this posterior area remain. So when in training, so please study one. Today I don't do this. So I share one case, previous case, maybe somebody remember. 72 years old male, sudden onset of left face hand leg weakness and also numbness. So when he wake up, completely normal and he do exercise, and 5:30 a.m. suddenly weakness happen. And numbness also happen. And patients know very well about FAST and also know about our hospital. So almost the same time, maybe within 5 minutes, patients call to us and our ER team go to dispatch. Ambulance team pick up patients and come back. Patients past medical history, hypertension, diabetes, and stenting in the heart. So very high risk of stroke. No antiplatelet medicine. So about 2 to 3 hours in the ambulance after the onset. So we already doubt acute stroke. Then we ask ambulance team, some nurse here, to check the glucose, and glucose level 180. So no hypoglycemia symptom. And then 9 a.m.